Ladies and gentlemen, welcome to the next session. This session will focus on SMA, successes and challenges in SMA patient care in Poland. This is a satellite session for the first time, and this session is sponsored by Novartis. We have 3 presentations. The session will take up to 1 hour, and this is information on SMA patient care in a nutshell. First up, we will have Professor Anna Kostera-Pruszczyk, who will talk about successes of the SMA environment as concerns screening in Poland. The second speaker is Katarzyna Kotulska-Jóźwiak, who will talk about today and tomorrow in SMA patient care. Madam Professor will also discuss patient treatment. And I will be the last to take the liberty to speak. I will speak about a year's work on a report. Together with other authors, I could look into SMA-related issues. I hand over to Madam Professor. The newborn screening for SMA in Poland, our story and our successes. Ladies and gentlemen, thank you so much for the invitation to this conference. It is a great pleasure to speak about our successes, our joint successes. I think this is not a common situation, especially when we speak about therapies which are relatively new. When we speak about diseases which belong to the group of so-called rare diseases. We have already covered some ground here and the successes. Before I move on to the successes, just a brief note on my conflicts of interest. We meet in October of 2021, and for some time when speaking about SMA, I take the liberty of speaking about this important issue. We know that a lot is happening. There is some dynamic developments in the case of treating SMA patients. And when we speak about this great progress that we have been seeing over the recent years, I wish to underline that Poland is not a new and unknown country on the map of scientific research in the area of SMA. I just want to say that these years of efforts, among others, of my great predecessor, Professor Irena Hausmanowa, to name some of them, who had the clinic I am now heading, a lot of members of our team and other partners. This cooperation contributed to the fact that we are well versed in the map of SMA treatment and developments in Poland. So I will just quote a couple of studies which took place before we identified the gene in register. Excuse me, we're having a technical hitch. The developments have been based on observations of the progress of the disease. SMA is quite homogeneous in terms of genes and also its clinical picture. We have some well-defined criteria which stem from the period before genotherapy was available in the pre-symptomatic stage, and the motor condition which patients were capable of achieving during their life. And this translated into the expected year of life. SMA is a disease whose onset starts in infants, in newborns. Without pharmacological treatment, it leads to death, and this is not possible to prevent. Children without pharmacotherapy did not reach any milestones in their development. They could not sit up on their own. They could not walk on their own. These are the patients whose functional condition without therapy is sitting up on their own. And depending on the progress and severity of SMA, some patients were capable of walking on their own, but even if they did, they soon lost that ability. Now on the medical map, we have 3 drugs registered in Europe. We have a Spinraza, this drug therapy, and the gene therapy of Zolgensma and Evrysdi, which is administered orally. What is important here is the element which affects the symptoms. Are the genes which are present in this disease, which is SMA1 and SMA2. What is important is the number of copies of the SMN2 gene. And depending on the number of these genes and their copies, it is possible to predict the progress of the disease. What is absolutely key is that SMA, especially of the first type, is a disease which progresses. SMA2 has some very quick progress due to the fact that motor neurons deteriorate very quickly. And this process is generally believed to be irreversible due to the weakening of skeletal muscles. Research from 10 years back and more, it shows that without pharmacotherapy, without treatment, the number of motor neurons deteriorates and drops, and that time is crucial. It is most important to provide treatment as quick as possible. That is also our crucial objective. So we are dealing with patients suffering from the same disease based on the same molecular mechanism, that is SMA, spinal muscular atrophy, and they show a spectrum of symptoms which are consistent. Many patients reach adult life. These people function normally in the society. What is very important is that SMA has a pre-symptomatic phase. We know the natural history of this disease, and since some time we have effective pharmacological treatment. So this fulfills the criteria outlined at the end of the 1960s as the criteria which should be fulfilled when we want to include a disease into a national screening program. Newborn screening programs have not been invented in Poland, of course, in the context of SMA. They have been performed in different places in the world for many years now. Depending on when these programs were introduced and to what period the available data date from, what is important is the availability of pharmacotherapy, and a recent publication summed up the state of affairs in many countries. In more than 50 analyzed countries which had available pharmacotherapy, about 30 admitted pre-symptomatic treatment with nurinesen. And there were also countries which reimbursed such therapy for pre-symptomatic patients with oral treatments with the third type of drugs. But of course, the figures were lower here. What is worth noting is the number of copies of the SMN2 gene, so the copies which at least indirectly determine the course of the treatment from the onset to the most severe stage of the disease. And this is also available for pre-symptomatic patients with 1 or 2 copies or 3 of the SMN2 gene. And of course, the present situation is one where individual countries provided newborn screening for the whole population. In the majority of countries, similarly as in Poland, at first there were pilot programs which were then expanded to cover larger and larger populations of children. And of course, there were some obvious experiences drawn from this: how many children are diagnosed in the pre-symptomatic stage, in how many children it is possible to start the pharmacological training, and subsequent years of observations would provide information on the effects. I am showing you this slide to draw your attention to the fact that Poland is still part of a quite exclusive group of countries which recognize the importance of pre-symptomatic treatment of SMA, and this is an important step. Why is pre-symptomatic treatment of SMA so crucial? What do we know about this? In the world, there are 3 clinical trials pending, and these trials are focused on pre-symptomatic populations. A study on nusinersen, a gene therapy study, and a clinical study in pre-symptomatic children on oral drugs. And the reasons for presenting this are quite clear. So, to say the least, the schedule and the timeline for this. What is most important is that pre-symptomatic treatment of SMA is most effective. Of course, treatment of SMA in the symptomatic stage is also fully justified and effective, but our intervention is most effective when administered in the pre-symptomatic stage. What we know from observation of the children who received treatment before they developed the first symptoms, the vast majority of them are gaining motor milestones and are witnessing motor development. And they are part of the gene program. We can see their progress in terms of motor functions. They develop almost in the same way as their peers, or in the very identical way as their peers. So it seems that effectiveness of this treatment is better in children with 3 copies of the SMN2 gene. The newborn screening program in Poland started in 1994. Phenylketonuria and hyperthyroidism covers about 90% of newborns in Poland. And now that we have 30 diseases which are included in the newborn screening program, along those which I mentioned before, and this program is coordinated by the Institute of Mother and Child in Warsaw. This year, we launched the screening in April, and by the end of this year, we will cover 141,000 newborns in Poland, and starting from the next year, we hope that we will cover all newborn children in Poland. We succeeded in identifying the first 5 babies with SMA, and 4 have already started disease-modifying treatment. So we are planning this newborn screening program for a period of the upcoming years, and we are capable of offering this intervention very quickly as possible to achieve this optimal treatment effect. What is our recipe for this success? Because this is an immense success. Of course, earlier clinical activity before therapies emerged, research activity. Also the fact that for more than a decade, we have great registry data which help us take decisions on treatment. And also very tight cooperation with patients with SMA, with their families, with experts on SMAs, with the families of patients suffering from spinal muscle atrophy. What seems nonetheless important, I think that the presentation was paused, perhaps the speaker lost her internet connection.
Proszę Państwa, utraciliśmy połączenie. Może nam się uda jeszcze przez kilka sekund. Jak Państwo...
I'm sorry, we lost the connection. We're hoping to reconnect, but what you have in front of you on the screen is a sum up of the presentation. I'm afraid we lost the connection. In a moment, we will have the opportunity to talk to Madam Professor. We will have her join the discussion, and I'm sure that we can make up for what we are missing now. A big thank you to Madam Professor. I don't know if she can reconnect at the moment. And let's move on to the next presentation, which is nonetheless important because it points to important issues today and tomorrow in SMA patient care. And I hand over to Katarzyna Kotulska-Jóźwiak to give us her presentation.
Hello, ladies and gentlemen. Thank you for the invitation.
Bardzo dziękuję za udostępnienie prezentacji. Mam nadzieję, że wszystko widać.
I hope everything will be visible. I will be continuing what you've already heard before with regard to SMA. I will be talking about what the situation looked today, how it looks now, and what we expect in the future. But I would like to point out that we will be talking about challenges not only for professionals with regard in the sense of doctors, physiotherapists, and other healthcare professionals, but also for the entire system of healthcare. I am experiencing a problem with changing the slides and moving forward with my presentation. I'm not sure if I'm being heard. Yes, it seems the technical glitch has been corrected. As you can see, over the recent years, we have experienced significant changes in terms of diagnostics and treating of SMA. For many years, for almost 100 years, all we knew was that the disease exists. We were able to describe it. Those clinical descriptions were very important because they created the database for what happened later on. It gave rise to an explosion of preclinical trials about where the disease comes from, and then studies on developing diagnostic and treatment procedures. And this led to the creation of free drugs which can be used in the treatment of SMA. In the natural course of the disease, that is when there is no intervention, when the disease is not treated, there is always weakness of muscle and deterioration of muscles and the loss of more and more types of life functions by the patient, especially in type 1. It's in SMA type 1, it happens most rapidly. Less rapidly in type 2, where the onset is in the second half of the child's life. In SMA 3, the progress of the disease is even slower, but yet the deterioration is always there. And on the basis of I hope the next slide will show us that on the basis of this natural course of the disease, we can talk about this old division into different types of SMA. Type 1 is the most common one, which is the most severe one, happening in newborns. Type 2, Type 3, and Type 4, which is also very rare, where the first symptoms are observed in adult patients. But please observe that this division takes into account the best possible condition of the patient pre-symptoms, so does not assume any improvement, which is important for the treatment and how we look at it. Moving on to the next slide. Now we are experiencing a huge number of changes related to different aspects of SMA patient care. This results, first of all, from the development of new therapies, and also from the fact that in connection with those therapies, we had many activities which led to increasing social awareness and awareness among the healthcare professionals about the disease. We have led to the screening of newborns, which we have discussed already, and we have reached a situation where we can treat patients pre-symptomatically. And moving on to the next slide. So currently the division of SMA types should not look the way it used to, where we divide patients into the previous types of SMA, but we should categorize them depending on their current functional status. Is the patient a walker? Is the patient a sitter? Or is the patient a non-sitter? And we also have the subtype of a pre-symptomatic or non-symptomatic patient, where the type of disease is not possible to be determined. The treatments that are registered are intended to increase the amount of the protein which is lacking in the natural course of SMA. But in the future, in the clinical trials, we also have drugs which will probably change the way that the disease will be addressed. So the drugs will change the way that the muscles behave and will change their the muscles' tendency to contract, and this will impact the patient's functionality. The free therapies which already have marketing authorization are therapies which either increase the production of proteins based on the SMN2 gene copy, or delivers a copy of the SMN1 gene. That is the gene therapy. All therapies were carried out, were tested in numerous clinical trials. Nusimersen was tested on patients that were pre-symptomatic and with patients with significant symptoms. And nusinersen has been researched most thoroughly because the study started in 2012. The other available therapy uses the virus vector, which delivers the correct copy of SMN1 gene. The vector is obviously not an infectious type of a virus. Here we have various studies which involved patients with type 1, which were pre-symptomatic, and patients with SMA type 2, which were administered the drug intravenously. We also have data from 1,400 patients who received the drug as part of standard clinical practice across different countries. The situation for risdiplam is similar because with the difference that apart from the fact that the studies covered patients with SMA1 and pre-symptomatic patients, we also had a big emphasis on patients with later onset of the disease. Currently in Poland, nusinersen is available as part of a drug program. It is administered intrathecally. The other two drugs are not reimbursed in Poland. Currently, negotiations are being held in the Ministry of Health. Risdiplam is or was actually available for a quite significant number of patients. I've already mentioned that all drugs have been tested on SMA1 and all have demonstrated significant efficacy compared to the natural course of the disease. On this slide, you can see the results of the patients, the improvement of the patient's condition after administration of the three discussed drugs. Basically, there are no patients in whom the condition would deteriorate. We are only talking about improvement, which would not otherwise be possible in the natural course of the disease. When it comes to care over patients with SMA, we require various types of care because it's not only the question of muscles, it's also scoliosis, irregularities in the bone structure. This often requires not only orthopedic care, but surgical procedures, especially for scoliosis. Such patients also always required ventilation, so respiratory support, nutritional support, and additionally, patients like that always had to be under the care of geneticists who would support the family. Basically, it was a multi-specialist palliative treatment, and the introduction of the disease-modifying treatment results in a situation when we are talking about a different type of patient, where the patient, after the patient starts treatment, after the symptoms have already appeared, it's so a patient who received treatment pre-symptomatically will improve with regard to motor functions. But still, this patient will require rehabilitation and neurological support, however, to a lesser degree with regard to respiratory support, and other orthopedic problems will definitely appear, especially in patients who normally would have had SMA1 but received the drug but are attempting to walk. We have a significant impact of the hip disorders that affect such patients, and they have to be addressed. In patients who have received the treatment post-symptomatic and pre-symptomatic, the needs with regard to rehabilitation will look completely different. So we are facing new questions. When can we decide that certain types of assistance can be discontinued? For example, nutritional support. When is it time to let go of such assistance? How should we define effectiveness of therapies? This is of particular importance for the decision on which of the three therapies to choose. We've already talked about results for pre-symptomatic patients who received the drugs. Here we have a comparison of results for patients who had 2 copies of the SMN2 and the patients with a worse prognosis. So patients who received treatment pre-symptomatically and post-symptomatically. So orange is pre-symptomatic and blue is post-symptomatic. So this early introduction post-symptomatically helps prevent mechanical ventilation, and no patient who was treated pre-symptomatically needs ventilation. And this also has impact on motor development. So similar observations when it comes to pre-symptomatic patients have been noted with regard to gene therapies. The vast majority of patients reach and hit subsequent milestones, usually without any delays compared to healthy peers. In this group of patients, we therefore have a set of different questions that we should answer. So is there a need to scale the improvement in such patients? Will some irregularities develop subclinically? Should, let's say, a non-invasive ventilation be used as a security, not to develop a bigger respiratory failure? So these are the issues that should be addressed by the decision makers and healthcare professionals. We've already talked about screening, so I will skip this part. I would just like to say about organizational issues with regard to care over SMA patients. First of all, it's a very well working drug program financed by the National Health Fund. Other drugs are available to a very limited extent. So early access or emergency access for risdiplam and also crowdfunding usually pays for the gene therapy. And we have a very dispersed system of multi-specialist care. However, what lacks is coordination of this care. So we definitely would need a program for SMA patients which would coordinate all the different types of care that such SMA patients need. So what we are looking for in the future is the minister's decision about whether the gene therapy should be financed from the medical fund. The decision should be taken in October. And we have to observe the progress of the patients who receive the treatment as part of clinical trials and drug programs. The challenges for tomorrow is selecting the optimal personalized treatment, if possible, if we will have actually the choice of drugs in Poland. We'll have to work on the criteria for establishing the effectiveness and indications for changing a therapy. And we also have to discuss the creation of a new non-symptomatic phenotype of SMA. To sum up, I would like to say that indeed we have been experiencing a breakthrough in SMA treatment, both with regard to the types of treatment and the early introduction of such treatment. A pre-symptomatic patient can remain a non-symptomatic patient, and I hope that this will be a route for other rare diseases to follow. Thank you very much. Thank you very much for this presentation. I hope you will stick around for the discussion that we will have after my presentation. I would like to sum up the most important issues which happened over the last year. Over a year ago, we started working on the program Time is Motor Neuron, the systemic challenges and recommendations for patient care in Poland. And I would like to show you what we've managed to achieve over this year and basically to summarize the entire scope of SMA breakthroughs, which without the support of the entire community of pediatric neurologists and other experts would not have happened. The SMA patient group is one of the most active ones in Poland. They have been cooperating with the National Health Fund and with the Ministry of Health. As part of our report, we looked at different issues, but by cooperating with our two representatives, Ms. Kostera-Pruszczyk and Katarzyna Kotulska-Jóźwiak, who were representatives of various institutions, I think that SMA is a rare disease of a disease which a few years ago was a very distant perspective with regard to reimbursement, and yet one of the Vice Ministers of Health, Minister Miłkowski, who was supposed to take part in the discussion, would assess the horizon of drug reimbursement. Our report offers also includes Ms. Chruścińska-Krawczyk, Mr. Dr. Jakub Gierczyński. So the two honorable guests that are here with us today, Anna Kostera-Pruszczyk, Agnieszka Słowik, Ms. Mazurkiewicz-Bełdzińska, and Kasper Ruciński, who was the representative of the SMA Foundation as the representative on the part of patients. When we started work on the report, it seemed that screening in Poland is not a sure thing because there was talk of various barriers. But it is year 2021, and we can see that the implementation of the first type of genetic tests, in this case of SMA, is going according to schedule, and we have the chance of finding children who are pre-symptomatic to start quick treatment. Obviously, diagnostics gives rise to hope because we can address very quick treatment in tiny infants. And treating pre-symptomatic patients is of key importance, although we know that still we have a lot of questions with regard to the duration of the treatment. From the point of view of diagnosis, the time from the diagnosis to actually treatment and symptoms was the key issue. As you've heard, this course of the disease can be very rapid, so the symptoms can start being observed very quickly. I think we can treat SMA as an example of a flagship disease, so to speak, where the system covered all SMA patients. So we are talking about treatment possibilities. We're not talking only about the youngest patients with the worst prognosis, but also patients with type 4 SMA, so adult patients. So access to drugs became a challenge in two regards. First of all, the introduction of nusinersen has changed the horizon. It has been a game changer. More and more centers were covered by the drug program. So now geographically there are no limitations anywhere in Poland. And secondly, the introduction of nusinersen also has introduced elements of coordinated, comprehensive care, so the possibility of consultations with experts from different fields of medicine. Over the next subsequent years of the program, we are observing an increased need for coordination. So by treating the patients, we give them the chance to be with us longer, to lead a longer life, but this is associated with greater needs to consult different doctors. On the other hand, rarely we have a situation where we have several subsequent introductions of new drugs for the same rare disease. I think that both speakers have already mentioned that we have very rich RCT evidence, but what is happening in the world, that's also the future, and we will discuss it on our session tomorrow, which will be devoted to real-world evidence. And the medical fund, for the first time, will give us the chance to look at gene therapy by comparing real-world evidence with RCTs. So access to drug is not only the possibility of reducing the expenditure on the part of the payer, but also maximizing the health effects. And we will be, as part of the medical fund, we will be able to assess the actual health outcomes. From the perspective of the medical funds, from the 5 therapies which were included in the list of drugs with high innovativeness, this all regards rare diseases, so only a small population of patients. So the 5 technologies corresponds to around 300 patients a year. So this offer is directed at small populations with a big chance of improving health outcomes. It is possible that in October we will see the first reimbursement decision regarding the medical fund and a rare disease with gene therapy. What the medical fund brought about and what was a big challenge for the payer was the fact that we are not carrying out in-depth clinical analysis. So assessments from different countries indicates greater chances for better health outcomes than the outcomes offered by the currently reimbursed treatment. And we have to analyze that. What is an important aspect of the entire system is that although those therapies are directed at patients with very bad prognosis, we have to keep in mind that we are facing a completely different phase of the disease, about how often those patients will be in the healthcare system and how the spending on those patients will change. So the scope of pharmacotherapy treatment is not sufficient because coordinated care with emphasis on care provided in the patient's home or in the vicinity of the patient's home is of key importance for the chances of success. What is emphasized by patient organizations that the introduction or 2 up to 3 different interventions for the same disease gives the chance for developing reliable registers. This is the future at which we have to look as the effect of the entire bigger picture. We have very quick screening programs in Poland. It's interesting, in 2019, nusinersen was introduced. In 2020, the screening program was introduced, and maybe in 2021 we will witness the introduction of the first gene therapy. So it's a very rapid development. This is all when it comes to my presentation. I would like you to visit the websites of, among others, HTA Consulting, which took part in the creation of the report. I am very excited and very hopeful for what will happen in the future with regards to SMA patient. Maybe this will bring along the introduction of coordinated care.
Chciałabym na sam koniec dzisiejszej sesji poprosić o
At the end of this session, I would like to ask for a short discussion between the two professors about the possibilities in SMA treatment and looking more broadly at rare diseases.
I have a question to both Madam Professors. What possibilities, what opportunities? I think we just have Katarzyna Kotulska-Jóźwiak with us. So a question to you, Madam Professor. What chances does newborn screening for SMA provide to Polish patients? How do you perceive this? How big is this success from the perspective of the healthcare system? This is unbelievable. It's an unbelievable success and an unbelievable opportunity. Because in the future, we will be able to deal with a larger group of SMA patients, but this disease will not be such a problem for the patients. They will not develop symptoms. They will not have limitations which are normally entailed by the disease. All they will need is the treatment. And irrespective of whether we're talking about nusinersen or gene therapy or the oral drug, Zolgensma requires only a one-off administration, but this will resolve the problem of this disease. And I have a second question. We speak of gene therapy, which is a different therapy than those used until now. And what is interesting for me as an HTA specialist and the HTA group, we know that the gene therapy requires only one-off administration. What are the expectations connected with this gene therapy? What do you expect after this therapy is introduced? Let me start from stating that this is not a therapy for everyone. It has its restrictions. It follows not just from registration-related issues, because this therapy is limited to certain age groups in different countries, but there are some restrictions. That's the main point. There are also some limitations following from the nature of this therapy. So the virus carrier, if the patient has antibodies or there are any symptoms of liver failure. But if such a therapy could be applied, if it could be applied earlier, so in the pre-symptomatic stage, then it would be possible for us only to follow up on the patients. So check up on them once a year to see if there aren't any adverse developments, or maybe even longer than a year. And that would be it. So this would just be a checkup visit at the doctor's. Of course, there would be a serious period at the moment of administering the drug, because that is when the patient requires a lot of care. But there is an opportunity for making SMA a disease unit whose patients never develop symptoms of the disease throughout their whole life. Why do I think that these checkup visits are so important? Because it will make it possible for us to take decisions on the therapy, to decide whether it is effective, whether there are any risks involved. So long-term observation surveillance is the only source of such details. If we look at the medical fund and its decisions, the 1.5 year long period of observation, of course, this will probably be shorter, because we can see from the screening performed in the first period, you have identified 5 children with SMA eligible for gene therapy. Madam Professor, when is the right moment to decide if this is effective? Is 1.5 years enough? 1.5 years is definitely too short a time. The European Commission has imposed an obligation of 15 years of observation. I think this is very rational, very reasonable. Of course, in the case of therapies, which builds into our cells, our DNA, and stays there, then we have to be ready to expect some symptoms which we cannot predict now. Nothing points to the fact that such symptoms should emerge, but we should be ready for such a development. That's why this monitoring of patients should be continuous. And this 15-year period required by the European Commission seems very, very reasonable to me. So looking at the Polish system, we have 2 years of experience in SMA therapy. Maybe we will have new technologies introduced to Poland. And maybe in 10 years, we will be able to answer the question, was it worth it? Is that true? No. I cannot agree with you there. When I look at our patients, who would probably be severely disabled, would have to use a ventilator if they were administered the drug. Now they're functioning normally, they walk around and run. You can't put a price on life with full motor capacity. In the case of pre-symptomatic patients, we're not talking about prolonging survival. We're talking about a radical change in the quality of life. A change which brings this quality of life much, much closer to the normal level of functioning for the normal population. So it's definitely worth it. Already today we can see proof that these drugs are working, that they're effective. But what we can't say is whether we have long-term certainty about their effects. I can draw a positive conclusion from this because it's rarely an opportunity to look at such a broad issue in reimbursement. I have a question about the treatment and the program itself. What is your opinion? How does COVID-19 impact treatment, therapy, the program? Have you experienced any limitations to accessible resources, any other restrictions? The nursing program was introduced right before the pandemic, then was developed throughout the pandemic, and now we will still be under a pandemic alert during the development of this program. So how do you see the impact of COVID-19 on the treatment of SMA patients in Poland? I think this is an exceptional situation, and it was brought about by the fact that the program, by introducing it at such a fast pace, so we added 200 patients every quarter. There were no new centers, new neurology wards, pediatric neurology wards created to accommodate for this. So it gained momentum, and so it just continued over the period of the pandemic. And there were COVID limitations, but they did not lead to excluding anyone from the program. And we do not get any negative signals concerning the program. Of course, there are fears, there are concerns about this happening, that someone will have to be excluded, but this never actually happened. What is very clear is that pandemic restrictions concerning SMA patients are limitations in access to rehabilitation. This has really deteriorated greatly. For many patients, this was a very big problem. Some of the patients would lose the benefits provided by the drug because they cannot continue this second axis of treatment, the second axis formed by rehabilitation. But of course, this doesn't concern only SMA. This is a general remark about rehabilitation during the pandemic. Madam Professor, what is your wish, if you could have a wish, about the postulates concerning international corporations, creating registries, advocacy So supporting patients who are very active as parents of SMA children, but also adults with suffering from SMA are joining the system. So if you could have three main wishes on behalf of the physicians, what would they be? In a perfect world, I would like to have access to all drugs and the knowledge to be capable to providing the right drug for every patient, so this specific patient would get the greatest possible benefit from the specific drug. The second thing, coordinated care. So the presence of clinical assistants who would be there for the patients, but also for the clinical staff, so that we didn't have to spend a lot of time on the phone with some administrative organizational issues to deburden us. That would be very important. And also the available space for this program, because if we can accommodate a new group of patients, that doesn't mean we have the right infrastructure, the rooms, the beds. Hospitals are still suffering from a shortage of infrastructure for patients, and I hope that this could change so that we could cater to the needs of more patients. And of course, other things, new restorative therapies. I have many dreams and wishes, and I'd rather not share them. Right, so a bittersweet ending for this session. I wish us broad access to SMA therapy. We are on the verge of introducing the second therapy, and we know that there are still some problems in pediatric centers. We know what is happening in Krokocim, in Krakow. So I wish clinical staff and physicians to find the strength to resolve the infrastructural problems, but also shortages in staff, so that we can have access to treatment in general. Thank you, Madam Professor. I would like to thank Anna Kostera-Pruszczyk, who had to disconnect for technical reasons, and I hope that we will follow up on this cooperation and search for solutions within the healthcare system. Thank you, and I wish you a nice and pleasant